Hey, Catherine, can you hear me?
Yes, I can.
Sorry, I had my sound turned down. Can you hear me all right?
Yeah, I can. Can you hear me as well?
Yeah, I can. Sorry about
Okay.
that.
No, that's okay. That's okay.
I had to go off and come back on as telephone kids so that I could record the session for Maria as well. Do you
Oh, yeah.
know roughly how many people are joining us, or do you have no idea?
I don't, because I didn't seem to get that original email.
Yeah, sorry, that's
No,
my.
that's okay. Because I was having a look through, so I'm not quite sure how many sites are joining in.
Okay, well, at the very least, we can record the session. Joanne, sorry, I can see you're here, but I can't see you. So, welcome. I don't know which site are you from, Joanne?
I'm from the Middlemore site.
Oh, right. We've already spoken with Middlemore before, have we?
I think you've been dealing with Dr. Mike Mayer.
Yes, yeah. Great. So you guys are potentially looking to come on as a primary recruiting site, is that correct?
That's correct.
Right, okay. I wasn't 100% sure, so I've put this is obviously a primary sort of a secondary site information talk, but I have put that Middlemore was potentially coming on as a primary site. So once we've made that decision, we can start lining that up for you, working with Mike, of course.
Thank you.
So do you know, Catherine, is Maria joining us?
She's here clinically today. I'm not sure if she if she has the a gap in her calendar or not. I ran into her like very first thing this morning, but
Okay.
yeah.
All right. No, that's no worry. Maybe we should do you think we should get going or should we give it a few more minutes? I'm not in any rush, so
Yeah.
we can give it a few more minutes and see if anybody
Yeah.
else arrives.
Yeah,
Okay,
and then I mean, worst comes to worst, we have it recorded, so then we can distribute it that way.
perfect. Sounds good. We'll give it another sort of 4 or 5 minutes to like 22, and then we can go ahead from there. Welcome, Moira. Which side are you checking in from?
Hi, sorry I'm late.
No, that's okay. We're still waiting to see if anybody's going to join. So you're actually on time. It's all good. Where are you dialing in from, Moira?
I'm from New Zealand. I'm dialing in from home. I work for Counties Manukau with Mike Myers and Joe Clements.
Perfect. Thanks. Thanks so much. Thanks for joining us.
Okay, thank you.
Morning, Dan. Sorry, I keep saying good morning, but it's afternoon there for you. Can you tell me where you're dialing in from? Can you hear me okay there, Dan?
Oh, hi. Yes, I can. Sorry, I didn't realize you were talking to me.
No, that's totally okay. Good afternoon. It's morning time here in Perth, but how are you, and where are you dialing in from?
Oh, thank you. I'm dialing in from Nelson Special Care Baby Unit.
Perfect. Thank you. Thanks for joining us. We're just giving it a few minutes to see if anybody else joins us, since both you and Moira have come on a little bit late. I think we did only send the invite out on Friday, so potentially people might have not yet seen the information. It's partially my fault for not being able to get my institute to set up Zoom for us. We're a Teams-based institute, so I apologize for that. But we're going to record this session, so we'll distribute to any other secondary sites that aren't able to attend or didn't get the information on time. I think we may as well go ahead. So I'm just going to, can everybody see the screen with the CIRCA DIEM PowerPoint presentation on?
Yes.
Yep, you can. Okay, cool. I did want to just see. Okay, lovely. All right, so kia ora, everyone. Thank you so much for joining us to hear a little bit more about the CIRCA DIEM study and how your role as a secondary site will sort of pan out from here. Maria has sort of given me an idea of how many of your sites are sort of interested in being secondary sites, so that at the moment there's no obligation to be part of it, but we would love to have you on board as a secondary site if possible. Middlemore is also here with us, and they are looking to be a primary recruiting site, but our other two primary recruiting sites are Auckland City Hospital and Wellington Hospital. So the CIRCA DIEM study stands for cognitive improvement through restoration of circadian rhythms in very preterm infants through environmental modification. I apologize if any of you have already seen this content. I'm going to go through sort of our study video and then give you some background information on why we've designed the study and why we think it's important to implement the CIRCA DIEM trial. Yeah, I apologize if you've already seen it, but I'd just like to recap for anybody that hasn't already seen it. So we'll go ahead and watch the study video. I hope that I've set it up okay, that you'll be able to hear the sound. I hope that it's even going to open my video. I might just have to stop sharing and go out into YouTube. I'm just going to copy this. bear with me, I'll get there in the end. I'm very unsavvy when it comes to can you all see and hear this okay?
So essentially, we're just trying to create a more normal environment for these babies. They're born very, very early and before they're ready to be born, so before their organs are ready to be born. And they're in that process kind of taken away from their mum, who gives them a lot of really important signals in utero or in the womb. Part of those signals are information about when it's day and night time. You might think, why does that matter to a baby when they're in the womb? But actually those signals, those rhythmic signals, really drive development of the organs. And the babies miss out on that when they're born prematurely. I guess we were trying to find a way to really get the light out of the baby's eyes, because light in particular is a really, really powerful stimulus for getting these circadian rhythms going. And we know that there has to be a certain degree of light exposure, but you also need to get rid of that light exposure at night time. So by removing that light, and that means all the light has to be removed in order to get the circadian rhythm turned off at night, or for the melatonin, the sleep hormone, to actually rise up to its maximum level. So we now got increasing evidence that these rhythms are really important for development of all of the organs. So it's just about maturation of the organs. We know that long term there are some implications for how the brain develops, or how babies, their propensity to develop other problems during childhood or adulthood, such as metabolic syndrome, so diabetes and obesity. It's been linked to cardiovascular problems, high blood pressure, for example. There is recent data showing it's linked to changes in their immunity and susceptibility to infections, as well as other neuropsychiatric problems, depression, anxiety, etc., maybe even autism as they're growing up. And there is also some link between the presence of a rhythm or the absence of a rhythm and susceptibility to cancer in later life. So it can really impact lots of different aspects over not just the short term, but very long term.
Alrighty, so I'm going to go back and share my screen again. I hope you all managed to hear that all right. I apologize for the technical issues, technical issue being me. Dan just gave you a sort of brief overview of our of what the study is about. That's our CPI of the study. She's the one that designed and enrolled, rolled out the protocol. So she's our guru on all of this circadian stuff, and she's wonderful and very knowledgeable. So I'll give you just an overview of what circadian rhythms are. So the circadian rhythm really is about how the physiology is entrained to the day-night cycle. So they're entrainable physiological, biological, behavioral rhythms that oscillate across the 24-hour day. So examples include our sleep hormone. We focus on this one quite a lot during the trial, melatonin, that provides the opportunity to get nice, deep, restful sleep. Body temperature peaks and troughs throughout the 24-hour cycle, blood pressure, our alertness, coordination, even cardiovascular efficiency and muscle strength. All of these things coordinate to the 24-hour day, and they're optimized to be either higher or lower depending on what our body needs throughout the 24-hour day. So examples of circadian rhythms include hormones, sleep-wake cycles, the metabolism, our body temperature, heart rate, blood pressure, and respiration rate. And really, they all sort of align so that at night we get that nice, deep, restful sleep. So things like increase in melatonin, decrease in heart rate, decrease in core body temperature. And then during the day, they kind of flip so that we're alert and awake to do what we need to during the day. Not surprisingly, happiness seems to be lowest at 6 a.m. when the alarm goes off in the morning, or perhaps you're finishing up your night shift. And so even our mood really is coordinated with the 24-hour cycle of circadian rhythm. Now, for the fetal circadian rhythm development, this begins in utero. The maternal circadian rhythm initially entrains that fetal circadian rhythm. So mum's body is basically teaching baby's body to have a circadian rhythm. That maternal fetal connection, it's really vital for growth and development of the fetus. And the fetus starts to show its own circadian rhythms later on in the pregnancy. So towards the end of the 3rd trimester, the fetal clock genes start showing their own clock. The suprachiasmatic nucleus, which is the biological clock that in the brain, that starts to show its own circadian rhythms, and things like hormones in both mum's baby and body's babies tend to align. We know that maternal melatonin exhibits circadian rhythms in the cord blood of newborn babies. So we know that there's really like this intricate connection through the placenta between mother and baby. Now, of course, in the event of preterm birth, that maternal fetal connection, circadian connection, it's lost for sometimes as much as the entire 3rd trimester. So if a baby is born 23 weeks, you're looking at up to 17 weeks of missing circadian information from the mother. So then these babies obviously go into the NICU, and whilst this is the only place for them, and developmental care in our NICUs improves every year, the environment is still quite unlike the womb. So with no maternal circadian information, the circadian rhythm development of a newborn premature baby is then further impacted by constant exposure to either bright light or darkness at inappropriate times of day to allow for obviously the high level of care. They're exposed to high levels of noise from the incubators, the monitoring equipment, other crying babies, and staff and parents talking, and they're subject to regular invasive procedures and pharmacological therapies. And all of these factors lead into circadian rhythm disruption, so further circadian rhythm disruption, on top of the fact that they've been born prematurely. So the biological plausibility here is that these preterm babies are born during a brain period development called the critical period. And during this period, there are several vital processes going on inside the brain, such as neural migration, apoptosis, synaptogenesis, and the beginning of myelination. So all really important in terms of brain development, and all linked quite closely to the circadian system. So impairment to the circadian system during this period can have ongoing detrimental effects into speech and executive function and motor function, language, that sort of thing. Now, the NIDCAP guidelines have sort of evolved over the course of, many years, but quite rapidly over the course of the last few years, the NIDCAP guidelines have been evolving. Initially, the NIDCAP guidelines recommended continuous dim lighting, looking at dim lighting to the research field is about less than 20 lux. It's basically darkness for 24 hours a day, and that was to emulate the uterine environment. What we do know is that either constant darkness or constant light are both harmful to the circadian system. So they confuse the circadian system, because if you're in constant darkness or constant light, the brain doesn't know whether it's daytime or nighttime. So, and then in sort of 2017 to 2019, this space really started evolving for the NIDCAP guidelines. And they've now started looking at incorporating some light exposure during the day, but it's really variable and still widely quite controversial in the nursing space about now starting to expose babies to light. What we do know about the womb is that we can't really replicate the womb environment. The womb is so much more than just a dark, warm place, because these babies would have been exposed to the mother's circadian rhythm signals. So including her hormones, her blood pressure, her sleep-wake cycle, and body temperature. Those are just a few of the circadian signals that would have been going on in the uterus, and you really can't mimic that in the NICU. There have been a few different studies that have looked at evaluated the cycled light in the NICU. Most of them have been really quite small studies. So you're looking at an N of 38 to an N of 41. I think there was a slightly larger one, but these all looked at either cycled light versus continuous light. And in all circumstances, the outcomes favored cycled lighting. So you're looking at a decreased length of stay and a decreased days of ventilation in this particular circumstance. There were some studies that looked at cycled light versus near darkness. A lot more NICUs practice a near darkness practice as their general standard care. So there were 5 trials looked at this, and one trial was slightly larger, so 169 infants in this study, but most of them were really small other than that. So again, you're seeing a decreased length of stay, increased day-night activity. There was no effect on retinopathy with the increase in light exposure, less crying post-discharge, and again, all of them favored cycled light. Some of these studies also looked at feeding tolerance, sleep-wake. So you're getting a range of different outcomes, and all are being favored in the cycled light intervention. But none of these studies were big enough that they could have said, all right, this is time to change practice. So we really wanted to explore that and create a study where we could have a larger sample size, a much larger sample size that would give us the final answer as to whether we do change practice. But we also wanted to include longer term brain outcomes, because we really want to know, is there if we are changing the environment of the NICU, is it affecting brain development and affecting the way that our children learn at an older age? So the CIRCA DIEM study is a multi-center, 2-arm parallel, prospective, randomized, open-blinded, endpoint controlled trial. And that's a mouthful of epic proportions there. But basically what it means is that the intervention cannot be blinded during hospital, because obviously it is very clear if a baby got the intervention or is in the control group, but that the endpoint is blinded. So we blind the Bailey's assessment at the end from our assessor. So the study is designed to investigate whether the infants born less than 32 weeks gestation are exposed to cycled light or noise from 72 hours after birth until discharge home, compared to those infants that are kept in that non-cycled standard NICU environment, have an improved cognitive score at the age of 2 years, corrected age. So our study cohort, we're looking to enroll 954 infants into our study group. So far we have 374 infants to date, that's as of this morning. So we're a little more than a third of the way through our recruitment, but really looking to speed up our recruitment now that we've sort of got everything in place and we've had all the teething issues. The primary recruiting centre that has recruited majority of those infants is King Edward, but we do have several other sites now in Australia that are also recruiting for us, and we want to bring on 3 sites now in New Zealand and a couple in the UK as well. So the inclusion criteria include all infants born less than 32 weeks post-menstrual age. Their initial care needs to be at a perinatal centre that does not cycle, light or noise, or at least does not make significant efforts to cycle light and noise. We do understand that in some areas of the NICU, that kind of happens as a default. We obviously need informed parental consent, no congenital abnormalities that would preclude the use of the eye masks and the earplugs. And then the exclusion criteria in particular include congenital neurodevelopmental abnormalities. Now, I looked that's obviously a very broad term, but we are looking specifically at any incidence of IVH greater than grade 3, and then any incidence of HIE as well. Any infants that are critically ill and clearly unlikely to survive until discharge. Any infants that are unable to return for that 2-year Bailey's follow-up, and any that are going to likely transfer to a non-participating unit before discharge home. So hopefully everybody that's listening to this talk is going to be a participating unit, and so you will help us include more infants that are going to come to your units before they go home, but that are going to be recruited at either Middlemore, Auckland City or Wellington Hospital. And also it's important that the infants are not already recruited to the PROTECT study. This is because we have both studies have the same primary outcome. We were actually willing to co-recruit with PROTECT and included as part of a sort of sub-analysis, and our statistician was willing to work with that co-recruitment process, but unfortunately PROTECT statistician has said that they don't want to do the same. So it's important that they don't go into PROTECT first. Probably not so important for you as a secondary site to know that, just the primary sites. Again, this is not important for you to memorize, but it's worth noting that the CIRCA DIEM study recruits into 2 age strata, mainly infants born less than 28 weeks gestational age, and then those born 28 to 32 weeks. The reason why we've done this stratification is because we're actually interested to know whether there's an age group where implementing the intervention would be optimal. So is it in those older infants where the brain is better developed, or can we implement it right from birth in the sort of 23 weekers and it's still really beneficial to them? So we're hoping we're going to get an idea using that stratification with our results. And importantly, all twins are randomized to the same group. So twin 1 will be randomized, and then twin 2 is allocated to the same group. So we're not getting one twin in one group and one in the other. So to give you an idea of our sample size and how we worked this out, we were looking for a 4-point difference in cognitive score with a minimum change to affect a change in clinical management. So our sample size came out as 954, that's 477 per group. We have adjusted for a 10% loss to follow-up and 30% multiple birth. And again, multiples going to the same group with a 90% power alpha of 0.05. Apologies, that recruited to date is out of date at the moment, but we said 374 as our current recruited infants. There are a range of secondary outcomes that we are looking at as well. So neurodevelopment is obviously our primary outcome, but we've got a couple of other neurodevelopmental outcomes we're looking at. Growth and anthropometry. My PhD looked at some of the circadian biology and physiology. I looked particularly at melatonin and cortisol, as well as some of the clock genes. We're looking at neonatal morbidity, behavior, sleep activity. So we've just started a new sleep study in WA as an extra sub-study to the main study. We're looking at health service utilization of very preterm infants and the mental health of the primary caregiver as well. So the whole basis of this study is the comparison between the intervention and the control group. The control group will receive all day your normal unit protocol, so constant dim or constant bright light, ideally not no larger difference than less than 100 lux difference between the day and night lighting, and you'll find that that's quite common in NICUs. The daytime lighting usually is up in the 70s or 80s, whereas the nighttime lighting is usually down in the sort of 10s and 20s. So there isn't usually a difference greater than 100 lux, we've found from working in our units here in WA and across the country. And then the intervention group, sorry, my computer seems to be on some sort of a timer. The intervention group obviously receives the eye masks and the earplugs at night, as well as a nice big cot cover over the top. So that occurs from 8 p.m. to 6 a.m. And then during the day, take the eye masks and earplugs off, and the cot cover comes away as well. And we would like to ask that you maintain a light level of 300 to 600 lux. This light level has been deemed safe by the Academy of Pediatrics, so the American Academy of Pediatrics. So we know that these light levels are safe, and they're achievable in most units across the country as well. What I can say is that if you don't know what 300 to 600 lux sort of looks like, don't panic. We can send each of your units a light meter along with some stock of earplugs and eye masks as well, so that you're able to test around your unit what sort of light levels you're able to achieve. And we then ask that all infants, both intervention and control infants, that you allow eye masks for phototherapy as is clinically necessary. The same with earmuffs. If they're needed for high frequency ventilation, then by all means you allow that for clinical preference. And then once those interventions have come off, then you can just start up the intervention again as you would if the baby is in the intervention group. But obviously clinical indication is given priority in all circumstances. And then we ask that you standardize the timing of neuroactive medications for all infants again. Ideally caffeine given in the morning. We recommend an 8 a.m. dose, and postnatal steroids in a split dose of 6 a.m. and 6 p.m. This is just a very broad overview of the schedule of events. So obviously all the consent, randomized and intervention process will happen at the primary sites. And then some of the prospective data collection will happen at the primary sites, and some may happen at the secondary sites. I'll give you an idea of what this is going to be in the next slide. And at the secondary sites will be involved in the interim follow-ups. There is obviously our Bailey's assessment, which is our final outcome. The primary sites will helping us to schedule those assessments. And we do a range of different other assessments in the interim, but that's all followed up through our REDCap database. We send out some surveys. We take some general movements videos through an app, the parents, ASQ, we collect some growth measurements, and then we collect some primary caregiver results as well. So MPAS and EPDS and the general anxiety depression score. There are a range of sub-studies that are going on, but at the moment it looks like New Zealand will not be taking part in those sub-studies, but we'll keep you updated in that space as well. So to give you an idea of the in-hospital collection, we do, in the primary sites, we do collect some light and sound monitoring. So once a week, we ask the primary sites to collect some data so that we can get an idea of what sort of light or sound the infant is being exposed to, as well as some growth measurements. And then at 36 weeks, again, we do growth. We do some average SpO2 and FiO2 collections. So we basically use 24 hours worth of charts to do that. A general movements assessment, and again, light or sound monitoring. Don't worry about the P-pod, we've stopped doing that. And then discharge home, we ask that you just collect some growth and neil morbidity data and just sort of give the discharge summary to your primary hospital. So we'll be very clear about what we require from the secondary sites. As a secondary site, you won't need to do any data collection with regards to light or sound monitoring. What we will ask you to do is maybe send us some growth measurements. So your primary site will be in contact with you when the baby is, let's say, day 28 or 36 weeks, and they'll say, would you mind taking a length and head circumference measurement for us and a weight measurement, and just sending them through to us. And that should basically be the extent of what the secondary sites are expected to do in terms of data collection. And then at the end, we'll ask you to send your primary site a discharge summary so that they can get an idea of anything additional that happened at your secondary site. So the role of secondary sites, you're obviously going to receive transferred preterm infants from Auckland City Hospital or Wellington Hospital, potentially Middlemore, as I've said. You're going to continue the intervention group for intervention babies. Of course, for control babies, everything is standard practice at your NICU, so you just continue on with what you would usually do. Like I said in the previous slide, we'll ask you to take some growth measurements, particularly at that 36 weeks postmenstrual age for both the intervention and control babies. It may be that you'll take growth measurements at one of those previous times, so the day 28 or the day 14, really is dependent on how quickly babies are moved through to secondary sites. And then provide the primary site with that final growth measurements in the discharge summary at discharge. And then just help us with any reporting of any protocol deviations. Maybe the eye masks and earplugs got forgotten one night, or anything adverse, any serious adverse events. We haven't had many in that space at all. But we do ask that you help us by reporting those promptly if you feel that they fall into that category. And we'll give your sites some training on how to determine that. Again, for the monitoring of light and sound, like I said, there's no formal monitoring required at secondary sites. But if you're unsure of the light levels in your units, we can provide you with a light meter for you to use for the duration of the study, and just check that the light is high enough for the intervention babies during the day. So I guess I'm going to go on to any questions that you have for those that have attended here today. And then you can just let me know. Just want to make sure that I start sharing. If there's anybody that's listening to this video sort of after the fact, by all means, you're welcome to send through your questions and I can answer them on email. I will put out my email address. Mine is either natasha.sorensen@telethonkids.org.au, or you can email our study email address, which is CIRCADIEM@telethonkids.org.au as well. So did anybody have any questions? I see we've got all of our primary sites have attended here, but this is, it's good because you'll be able to redistribute this video to your secondary sites. Thanks for joining us, Dr. Toldy. How are you?
Hi, I'm sorry I was a little bit late.
That's totally okay.
Yeah. Hi, everyone. My name is Gerge. I'm one of the neonatologists at Auckland City Hospital, for those of you who I haven't met. I'm not sure if you covered this at the beginning of your talk, but I was just wondering how far things got with the ethics approval and whether we should start planning for submitting the locality.
So I had hoped that both Maria and Jill would be able to attend today because Jill is our ethics and governance guru. She's amazing in this space. And Maria has been doing a lot of work already on, we're looking at doing a specific New Zealand protocol, just making sure that it is like very tied to what we want to do at the New Zealand sites, omitting anything that's sort of unnecessary in terms of information, and also taking into account the Māori consultation. We are working with Maria, and she's already submitted we submitted to ethics and we had our review.
Yeah.
That was last week sometime. And we answered a lot of questions there, and they've actually asked us to go back and just adjust some of our documents, and we're going to resubmit. But they're confident that the second time around we'll get it through. So yeah, I'm really happy with the comments that we got from that review. And so the answer is yes, we do need to start going ahead. So what I can do is just put you in touch with Jill, and she can start that process with you. Claire as well. Claire is our clinical trials assistant. So between the two of them, they'll start putting all of the documentation together for you, and they can really help you submitting any contracts or you know, any separate ethics. I think the consultation process is standard for all, or is it do you need to do a consultation process at each site? Do you know? You're nodding your head, Michael. Yeah, you think so. Okay. So yeah, that's something that I'll get Jill to get in touch with you, and we can start doing the consultation process at both your sites, and then we can just start ticking boxes in terms of what we need to submit.
Thank you.
Michael, go ahead.
Yeah, hi Natasha. Mike Mayer at Middlemore. I was just interested about, so we do quite a lot of open care, and I did sort of early on have just sort of mentioned that we do quite a bit of open care. Does that make any difference? So we would obviously at night, these babies wouldn't have any cover over the, you know, over their.
Yeah. So that is 100% okay. The cot cover is an extra bit. The eye masks do a really good job in terms of eliminating 99% of the light. And that's what's really important, is just keeping the light out of the eyes at night. The cot cover is just an extra. So if your unit practices open care, then that's absolutely fine.
Okay.
Any other questions? I might mention in terms of sort of the practicality of using the eye masks and the earplugs, there are like a few circumstances where staff have asked us if we can be quite flexible. So, for example, if parents are staying a little later at night, maybe dad's come in after work and he wants to have some cuddles or do a feed, by all means, leave the eye masks and the earplugs off until dad has done that and spend some time with his baby. That bonding is really important. And then when he goes home, you can put the eye masks and earplugs on. The other thing that we discussed is quiet time. So if your unit does practice quiet time during the day, let's say in the late afternoon or after lunch, whatever the case is, for a few hours, and you do turn the lights down, we are happy for even our intervention babies to participate in that NICU practice quiet time. Just don't put any cot covers on, and obviously don't put their eye masks on. We're happy for the lights to go down, but just leave it at that. We still want them to sort of be exposed to some light, or whatever is sort of available during that quiet time. And then the other question we get quite a lot is about suck feeds, and whether at night time, if a nurse is doing a suck feed and the baby is quite clearly awake, do they have to leave the eye masks and earplugs on? And the answer is not necessarily. So really it is situation dependent. But if you would rather do the suck feed with the eye mask off, we just ask that you try and situate, the nurse try and situate themselves in a sort of darker, quieter part of the NICU, or, you know, have a cover over the baby while you do the suck feed. So just try and limit the amount of light exposure during that feed. And again, if there's any clinical intervention or any necessary reason why suddenly the baby needs to go under light and be observed, or you need to do any sort of clinical intervention, that is obviously priority. If you are able to leave the eye mask on while you're doing that, that's optimal. But we understand that, you know, any clinical problems take preference over the study intervention, and we can just simply write up a protocol deviation in those circumstances. They're few and far between, but they obviously do happen. So go ahead, Michael.
Sorry.
Yeah.
So we had a look at our light is pretty we're in a pretty dim unit. We normally seem to be running at about, even in the day, maybe if we're lucky, we'll get 20. It's between 8 and 10. And that's even in the day with the sort of passage lights on. And we found even turning the lights on in the individual space, we only get to like 45. Joanne did manage to sort of shine a light and bounce it off the walls and stuff, and we got up to about 200, I think. But that's, I don't know, we're going to be able to get to 300.
It's quite difficult, and I do understand there are a lot of units that are just so dark. It's really difficult. And I was discussing with somebody at one of our surgical units here. They wanted me to weigh in on how to design a new NICU in terms of lighting. And I don't know that I'm qualified to work in that space, but it is difficult. So I guess we would need to. So have you got a light meter with you? Did you get one?
We've just used, there is one on the baby Leo. I don't know how accurate that is, but we've also just used a phone app. We don't have a proper meter as such.
Okay. I'm happy to send you like an official one. You can see if there is any difference. Probably the phone works as good as any other. Yeah. But let's just sort of explore, and I might get you to do sort of an official audit and just give me an idea of what the sort of light exposure is across your unit, and then we can make a decision from there.
Yeah, I think that'd be good for us to do as well, just to see where we're at. Sort of, we haven't got a purpose designed NICU, and it's it's pretty dark.
Yeah, I understand. It's a problem with a lot of units, and so in some regards, units have chosen to come on as a secondary site instead of a primary recruiting site, just simply because they weren't able to achieve that minimum of 300. But if there are areas in the NICU where you can, we may be able to work with it. We obviously don't expect you to be able to move babies to certain areas of the NICU just for research purposes. So it would be something you'd have to just really consider.
Okay, thanks. Yeah.
No worries, Michael. Did anybody else have any questions? I'll obviously, I'd be happy. So we'll distribute this to all of the secondary sites, but I'd be happy to meet individually with each of the secondary sites to do some sort of nurse-specific training, answer any questions that your nursing staff have, basically do an in-service. And again, we can provide you with light meters, your own stock, so you've got a little bit. So the primary sites will send you stock with each baby, each transfer. But if you just need some as a backup as well, we can do that. Michael, if you Middlemore do come on as a primary site, something relevant to Goodley as well is we will do extensive training with your research team in terms of how to do recruitment and what to say to parents and how to execute everything in the protocol in terms of monitoring and collecting growth measurements and what we require in terms of data collection. So there'll be a lot more training to come. So if you do come up with any questions, by all means send them through, but I'm assuming they will be addressed in those circumstances as well. All right, well, if nobody has anything else, then I'm happy to leave you be and give you back 7 minutes of your time. Thank you very, very much for joining me, and we look forward to working with all of you.
Thank you.
Thanks so much. See you.
Thank you.
Bye.
Thank you.